Anterior chamber phakic intraocular lens explantation, posterior synechialysis, and Phaco surgery. We are going to present a high myopic patient with anterior chamber phakic IOL, 360 degrees pupillary synechia, both haptics trapped in the angle, and iris atrophy. We performed IOL explantation, posterior synechialysis, and Phaco surgery in the same surgical procedure. We used mannitol before surgery and peribulbar anesthesia. We performed paracentesis and injected adhesive viscoelastic to protect the endothelium. The eye had endothelial cell loss with a cell density of 1,400. With a Synechialysis lens manipulating hook and rotating maneuvers, we managed to release the inferior haptic of the lens. Then we performed a 2.5 mm clear cornea superior incision to facilitate the manipulation maneuvers to release the superior haptic. We used cohesive viscoelastic and 2 manipulating hooks. It was impossible to release the superior haptic, and we decided to cut the haptic with Vannis scissors and to remove the IOL in 2 separate parts. We measured the IOL optic diameter with a caliper in order to enlarge the corneal incision. We removed the IOL with the type of forceps used in the time of extracapsular surgery to implant rigid PMMA intraocular lenses. The superior haptic was still trapped in the iris, and we managed to remove it with gentle maneuvers following its outline. We tried not to damage the iris. After removing the IOL, we sutured the incision to continue with the Phaco surgery with a closed anterior chamber. The cornea was losing its transparency during the surgery, and at that point visualization was very difficult. With viscoelastic, we opened the pupil at one small point. Then, with the spatula, we managed to release the pupil completely. Greasehaber disposable iris retractors were used to dilate the pupil. We washed the visco with irrigation. Then we injected air and trypan blue for 1 minute to dye the anterior capsule. We injected viscoelastic and performed the capsulorhexis with forceps. Because of the great loss of corneal transparency, it was very difficult to continue with the surgery. We decided to remove the corneal epithelium and put visco on the cornea. This was the key to completing the capsulorhexis successfully. Then, as in any current phaco surgery, we performed the hydrodissection, hydrodelamination, and phacoemulsification of the crystalline lens. An Acrosoft one-piece monofocal IOL was implanted in the capsular bag. Vision recovery was perfect, 20/20, but the patient complains of monocular diplopia and glare due to the inferior iris defect. We tried to adapt a cosmetic contact lens, waiting for patient adaptation, but the symptoms did not change. 10 months later, we solved these symptoms by implanting a partial aniridia sulcus ring. We used topical anesthesia. The pupil did not dilate a lot despite the mydriatic drops. We performed 2 paracenteses and injected adhesive viscoelastic to protect the endothelium. Cell density was 1050 after the last surgery. We performed a 4.5 mm clear cornea temporal superior incision. We injected cohesive viscoelastic under the iris to create the space to implant the ring. With the help of thin forceps and a Synechialysis lens manipulating hook, we introduced the aniridia ring behind the iris. We sutured the incision and the viscoelastic was washed. We injected acetylcholine to check if the aniridia ring was in the correct position to cover the iris defect. Glare and diplopia disappeared from the first day after surgery. Uncorrected visual acuity was 20/25 and best corrected visual acuity was 20/15, with a refraction of +1 minus 1.5 by 155 degrees.